Hi everyone, this is Mr. Neil Wright here, also known as the Wax Whisperer. Thank you for joining me in my latest video. This is of a patient who has to attend to have their ears cleaned out every 3, possibly 4 months. And so therefore it's quite a chronic issue for the patient. On average, if a patient is what I deem a waxy client, so I'll explain what a waxy client is in a moment. On average, they would need to have their ears cleaned out every 12 to 18 months. Now, that can vary. Some patients, like this particular patient, albeit rare, has to attend every 3 or 4 months, whilst others maybe every 6 to 10 years even. So when I say a waxy client, all of us, the whole population, have earwax. It's a human natural secretion produced in the ear. But for the majority of us, and I would say between 90 to 95% even, the earwax naturally migrates out of the ear, or there's not enough earwax to cause the individual any problems. So for example, for myself, I do have earwax, but the earwax naturally migrates and it's never ever caused me a problem. I've never ever had to have it removed. Professionally, it just comes out by itself. So the remaining 5 to 10% of the population, unfortunately, for one reason or another, they do have a chronic buildup. Now, with this particular client, the earwax consistency makes it really, really hard to remove. This is the type of earwax consistency that I most dread, although I enjoy removing it as well because it's a challenge, but it's very sticky, very glutinous, and for those reasons, it's very hard to suction. I can't use any other instrument because of the consistency. Obviously, with an ear hook, it's just going to slice through. It's just too soft. Same with forceps. On a Jobson horn, I may be able to remove some wax laterally, so near the entrance where we are now, but this is all smeared over the eardrum. The problem got so chronic for the patient that we actually did refer the patient to a local ENT to see if there's anything that can be done, which may may not stop the wax from forming again, but at least reduce the regularity that they have to have their ears removed. And the reason for that, you will see it a bit later, the patient's got this dip near the eardrum. We call it the inferior recess. So as the ear canal approaches the eardrum, about a half a centimetre away, it narrows inwards before it narrowing back out again. And it narrows back inferiorly, so downwards towards the eardrum, and also anteriorly, so towards the front of the eardrum. And that creates a trench called the inferior recess. So it's like a little basin, if you like, or pothole near the entrance, adjacent to the eardrum at the bottom. And similarly, there's an alcove that's created to the right-hand side of the eardrum, so to the front. And in the case of the right ear, that'll be the right-hand side of the eardrum. And quite often, wax can get trapped in that region. But this patient's inferior recess is probably the most prominent and most deepest inferior recess I've seen in a client. And so we can see I've managed to clear this wax out of the ear. I can see the eardrum, but we can't see the bottom part of the eardrum, and that's because the ear canal itself, it narrows inwards and it dips back down. And in the past, the patient has had wax that's got trapped in there, and it's been really, really hard to remove because it's difficult to obtain access. And I just wondered maybe if there's anything that surgically can be done to just widen this patient's ear canal, especially the base of the ear canal. So a procedure called a canaloplasty or myotoplasty, where the shape of the ear canal can be altered somewhat. And you may have noticed posteriorly on the left-hand side, you can see there's some residual wax, sticky wax there. There's a ridge there, and the ear canal widens. You can see that the wax is formed and filled that ridge to the left, just here. Now, the patient's had no previous ear surgery, no previous chronic ear infection, so this is an anatomical, I wouldn't say abnormality, but an anatomical trait that the patient was born with, it would appear. And so sometimes having ridges like this in the ear canal and dips as the patient's got near the eardrum, these can be potential causes for wax impaction. So the wax tries to come out, but it gets trapped in the ditch, or it gets trapped in that ridge to the left. Now, the patient's symptoms are completely alleviated. I'm just trying to remove this residual sticky wax. It's very, very difficult to do because we can't It's very hard to suction. We can't scrape the ear canal to scoop it out because it would just be so uncomfortable for the patient, because this is the bony part of the ear canal. Sometimes you receive comments, or when I used to have them activated, that why did I leave this or why did I leave that? And that's because it's for patient comfort. The inner 2/3 of the ear canal is literally a thin layer of skin. So our skin, any other part of the body, it's got 3 layers. You've got the epidermis, or the outer layer. Then we've got the dermis, and that's where the hair follicles are. We've got some erector muscles attached to the hair strands, the hair follicles. And then you've got a subcutaneous layer, which is filled with insulating fat and connective tissue. And that's about a millimetre in thickness, this general skin. And that skin that I've just described is actually lining the outer third of this patient's ear canal, and all of our ear canals, the cartilaginous portion. But the inner 2/3 of the ear canal, the bony part of the ear, we only have 1 layer of skin, and that's the epidermis. So that's less than 0.1 millimeters in thickness. So it's 1/10 of the thickness of normal skin that's lining this region. So this is the cartilaginous portion that I'm working on here. So this skin is thicker, it's a millimeter thicker, it's got those 3 layers, so it provides a buffer effect. And of course, cartilage itself is semi-flexible and malleable. But where I am now, this is the bony part. We're going to be really, really careful, because this thin layer of skin is directly lining the bone, and the bone is rigid, so it's sensitive. And this skin that lines the inner 2/3 of the ear canal, it doesn't provide a buffer. There's no insulating fat or cartilage. It's very, very thin. So that's sometimes why we leave a bit of wax, particularly medially towards the eardrum. A bit of wax is good for us guys as well. So showed the video back to the patient, weren't concerned by that little bit, and the patient's fully aware if we try and attempt to remove that, it's going to be too uncomfortable. I did remove a lot of it, mind you, so it's just some residual sticky wax. And no doubt the patient will be back in the new year. I hope you all guys are having a lovely evening tonight, whatever you may be doing. You may be celebrating it with family at home, or going out, friends and family. But whatever you are doing, please do enjoy the remainder of 2022. And I hope you all have a great start to 2023, an amazing new year. Do stay tuned in the new year. I've got loads more videos to upload. Take care. Speak soon. Bye.